Welcome back. So tonight, introducing our first guest, we have a very distinguished guest coming all the way from Brazil, Dr. Marcelo, who's a consultant surgeon. Good evening, Dr. Marcelo, and thank you very much for accepting our invite here in Kuwait.
Good evening. It's a really pleasure to be here in Kuwait. It's my first time here, and I'm loving the country.
How are you enjoying our weather?
Oh, it's hot, huh? Even for a Brazilian, it's hot.
So, Dr. Marcelo, can you kindly introduce yourself to our viewers, and can you introduce your specialty and your areas of interest?
Okay. I'm a general surgeon. I have a specialization in the laparoscopic surgeon that I've done in France like 15 years ago. And I have the master degrees, and I have a PhD, and I'm a university professor in Brazil. I'm responsible for the biomaterial science in my university. And also I'm leading of a postgraduate course in minimally invasive surgery. And one of my preferred activities as a surgeon is bariatric surgery.
And of course, bariatric surgery, as we all know, is the hot topic in Kuwait, and everyone really keeps asking us to bring someone back for to speak about the bariatric surgery. So, why are you here in Kuwait? Why are you visiting us in Kuwait, Dr. Marcelo?
Okay, that was a very kind request and invitation of two of our ex-fellows that went down there to my city, to my facilities, to learn a little bit more about minimally invasive surgery and bariatric surgery. And these guys, Dr. Mohammed and Dr. Saud, they invited me to participate in some workshops and surgeries, live surgeries with transmission in the hospital of Miri. So that's why I'm here.
So it's lovely having you, Dr. Marcelo. So if we're going to speak about mainly about bariatric surgery, so what are the indications for bariatric surgery in general?
That's a good question, especially to people in general. The indications of bariatric surgery, they're worldwide the same. People that had the BMI of more than 40. What is a BMI? Is an index, the body mass index. And you can obtain this dividing the weight in kilograms by the square of height in centimeters. So if you have this index more than 40, that is a formal indication for bariatric surgery. Or if you have it between 35 and 40, and you got a comorbidity like a disease that is caused or it's linked to obesity like hypertension or diabetes, then you have also an indication. So BMI between 35 and 40 or more than 40.
All right. And what do you do with if anybody comes to you with a BMI that's less than 35 and still insisting on some sort of weight reduction surgery? How do you deal with those patients?
This is a very good question, especially in the day-by-day basis that as a surgeon we face this kind of problem every day. This is not exactly a problem because people doesn't know exactly if they have indication or not. So they're over there to know if they can be operated by a bariatric surgeon. But nowadays things are changing because of the diabetes. Diabetes is an epidemic worldwide, and it's a very problematic disease. I mean, you can have a lot of problems coming from diabetes in long term. So we are trying to treat diabetes by bariatric surgery. That in this particular case, the name is metabolic surgery, but it's something similar to bariatric surgery. So if the patient comes with a disease like diabetes and a BMI less than 35, in some countries we are allowed to operate these patients.
Dr. Marcelo, a lot of patients here in Kuwait, they go to the clinic and they say, I want surgery within like a week. How do you usually prepare your patients for surgery, and do you usually have such patients wanting it within a week and actually getting their surgeries within a week?
Again, it's a very good question. In my facilities, I would never do that. bariatric surgery is something for life. It's changing in behavior for life. So it's a functional surgery, completely different for example, when you take off a tumor. It is a surgery where the patient must be very well informed before doing it, because after doing that, behavior has to be changed. So what we used to do is put patients in a multidisciplinary team, and this patient has to do a lot of consultations before being approved by the surgery. And during this period, patient can be not be approved. So I'm very restricted about this.
All right. And usually, what are their expectations? And is their expectation post-surgery usually met?
The most part of time, yes. The most part of the patients, they have the expectations. The target is we can achieve this. But you know, when we talk about the expectations, people always think that they could be better, they could go farther, and sometimes we cannot reach this. In general, I can tell you that bariatric surgery has wonderful results. In general, they're very, very good.
And how successful is bariatric or weight reduction in actually treating diabetes and hypertension?
We got a control of diabetes, at least a control, more or less of 80% of the cases, depending in a lot of factors. For example, for how long the patient is diabetic, and if he's been treating with insulin, or you know, there's a lot of strategies that are important when you talk to this kind of patient, because expectation here is very important too. They are patients with the important disease. So more or less 80%. And the hypertension is a little bit more than this, especially if the patient has the disease for a period less than 10 years.
All right. Dr. Marcelo, if a patient regains his weight after sleeve surgery or after a weight reduction surgery, is that considered a failure?
It is medically speaking, it is considered a failure. But when we talk about failure, we have to open our minds, because failure must be viewed in the point of view of the surgeon and of the patient. A patient that loses, for example, more than 60% of his excess body weight is a very good result. But maybe for that patient, he wanted to be leaner than this.
Yeah.
So depends on the point of view. In general, we reached a very good very good success. More or less 85% of the patients are satisfied, and we as doctors are satisfied. We are satisfied too.
And what are the causes of those like 20% that are actually categorized as failure of surgery?
The failure of a surgery can be categorized as a patient losing less than 50% of their excess body weight. And this can be, the reason for this can be a lot of different things. You can have a technical problem in the surgery, but the most part of the cases are the behavior of the patient is not it's not very good. So patients start consuming a lot of sweet. So this causes a failure of the surgery in the most part of the time.
Dr. Marcelo, the workshop in Emiri is usually for re-sleeves and like revisional surgeries. So if a patient fails his sleeve or fails to lose weight or actually regains weight, what are the options that they have, and how do you choose which patient gets which surgery?
Revisional surgery nowadays is the hot topic, because we still have a lot of patients, and I think we are going to have much more patients to be revised. So there are several options depending on the case, and depending on the case to be studied. So if you have a sleeve that is you find an anatomical failure, you can re-sleeve this patient. If you find there is nothing to do with a sleeve to be re-sleeved, then you can go for a bypass. So there are several options. If you have a patient that has not lose weight properly, you can add some disabsorptive procedures. That means you can make this procedure that is exclusively restrictive. The patient only eat a small amount of food and put something to make the food not to be absorbed as the way it is in general. So that's the concept of disabsorption.
So a lot of them, people are either opting for doing a sleeve again or going for a bypass. Is there a role for a band, or if there's a role for like balloons?
I think the road for band is finishing, really. This is the kind of surgery that worldwide is not being accepted very well accepted anymore. But sleeve and bypass, they are really the surgeries of the moment, and I think there are the indications for one and for the other. So it depends on the patient, depends on the expectations, and depends on the the team that is doing the surgery. Some teams prefer to do sleeves, some others prefer to do bypass. The results are quite similar, that's true.
Even in the long term, do we also have the same results regarding losing weight and
Another good questions, only good questions. So the results, the long-term results, depends on technique, but in general, bypass has a better results if your target is just losing weight. The quality of food intake and the sleeve is maybe it's better than bypass. I mean, the bypass is the long-term results of bypass are slightly better than the sleeve. So regaining weight is less common in bypass than it is in sleeve. So bypass, I think, is a more complete surgery, but sleeve is a very good surgery too because it's simple.
So
it's not exactly simple. Sorry.
You make it look simple when you work
yeah, it's
in
not
the
simple.
OT.
We have to take care with the words because it's a technically less complicated than bypass, but it has to be very well done. So it's not simple at all.
All right. So a lot of people or a lot of surgeons opt that if a sleeve fails, they go for a bypass. What if a bypass fails? What's the next option for the patient?
Another good question. If the bypass fail, you have to identify what's the problem with the bypass. If the problem is not the surgery, and we can have a very good idea if the problem is the surgery really, you have to refer this patient to the multidisciplinary team, and sometimes the psychologist is going to work much more than the surgeon. The scalpel is not always the answer for the patient's problems.
All right. And are there any complications that are specific to doing a re-sleeve or doing a bypass following a failed weight reduction surgery?
Every time that you reoperate a patient, no matter what kind of surgery you are doing, the complication rates increases. So a reoperation of a bariatric surgery always can take the patient to a complicated scenario. That's why we have to be very conscious about reoperation. We have to select the case, we have to study the case before opting for a reoperation.
What if the second sleeve fails again?
I'm almost without words. If the second sleeve fails, I will go for the bypass, but I have really to study this patient. I have to study the habits of this patient and the behavior of this patient. I always count on a psychiatrist to evaluate the patient. It's not only because of the problem is the patient, but we have to stress that the habits, maybe they haven't changed with the surgery, and that's maybe the reason.
Do you follow them up regularly? A lot of patients opt for sleeve because they just want to do the surgery and then that's it. They just want to lose follow-up. So do you usually, how often or how long do you usually keep your sleeves followed up before discharging them completely from your clinic?
I have patients that have been doing the sleeves for 6 years and bariatric surgery for 15 years. And these patients still come into my office. And I think it's important to make them very comfortable to come to the office. Bariatric surgery is something for life. So I always joke with the patient. This is for life, for yours until you die or I die. So we have to, it's like a marriage. I think it's important for the surgeon to be near to of the patient and to make the patient comfortable to come back.
And is it true that when you choose a sleeve, you don't have to worry about having supplements or having multivitamins, and that's why it's a more attractive option rather than having a bypass where you have to take those for life?
It's true and it's not true. Sleeve gastrectomy can lead to some nutritional problems. It's much less common than the bypass, but you can have deficiency of vitamin B12. That is quite common if the patient does not supplement their diet.
All right. I think we can go on our next topic. Dr. Marcelo, you're also here doing laparoscopic hiatus hernia repairs as part of our workshop. Can you tell our viewers, please, what is basically hiatus hernias? And
Okay. A hiatus hernia is dislodge of the stomach that, in general, keeps the stomach is kept in the abdomen, and you can have the stomach coming up to the thorax. The hiatus hernias are basically this, a malposition of the stomach, and this leads to a problem called esophagitis. Esophagitis is the heartburn, and that some patients feel, and this can be treated with medications, but especially I think in Eastern countries, the diet makes us very susceptible to heartburn and to this kind of situation, esophagitis. So the problem in this is when you operate and you have to reoperate, there are few options, and we are discussing this kind of options here too. What should you do when you have to reoperate a patient with hiatus hernia? We have presented some new devices that can be very useful for this kind of situation.
We have a question from one of our viewers asking if she has a hiatus hernia discovered while she is being prepped for a sleeve, does she have to have it repaired, or does she have to change the type of surgery because of having a hiatus hernia?
Yeah. If the hiatus hernia is accompanied by a reflux disease, that is not exactly the same thing, maybe she would be better operated by a bypass, but depends on the case. But this has to be very well investigated.
And do all hiatus hernias have to be repaired surgically?
Not necessarily. If you have a hiatus hernia that causes reflux disease, and it's not well treated by medication, then you have an indication for surgery.
Right, Dr. Marcelo, unfortunately we're running out of time. Thank you very much for passing by. Is there any words, or do you have anything that you'd like to say to our viewers?
I just would like to say thank you very much. Obrigado in Portuguese. And it was a pleasure to be here in your
Thank you. Thank you very much, Dr. Marcelo. It's been an honor having you with us tonight. We'll head on to our next guest, but first we're going to see a report that was shot in the Kwait Center for Autism, where they hosted a guest, or a yearly guest, who usually visits us, Dr. Harvey, who was giving us his annual lectures and his talks. So we'll see our reports and we'll be back.